All right. All right. Good evening and welcome tonight to our special event on headaches and concussion and our special guest, Dr. Ryan Pelo. Ryan, thank you so much for coming on.
Absolutely. Thanks for having me.
A really cool story how we met, but in the meantime, I'm gonna just read a little bit of his bio because it's pretty amazing. He's started as a physical therapist, then went on to get his doctorate of physical therapy, and he also holds a PhD. He brings his experience in brain injury, vestibular impairment, autonomic dysfunction to Kutcher Clinic in Park City, Utah, but they also have a few other clinics around the country with the goal of providing a comprehensive evaluation to identify the physiological factors limiting an individual's participation in daily activities and return to sport. Ryan earned his Doctor of Physical Therapy degree from Northwestern University in 2010, has been board certified clinical specialist in neurological physical therapy since 2014, received a certificate in vestibular rehabilitation in 2017 from the Emory University Duke University program. He has been licensed in trigger point dry needling since 2024. He also earned his doctorate of um, philosophy degree from the University of Utah in 2024. And with the focus of his dissertation on autonomic nervous system impairment in a post-concussion population. Before joining Kutcher Clinic, Ryan was a physical therapist at what is known as the Shirley Ryan Ability Lab, formerly the Rehabilitation Institute of Chicago, University of Utah Health, and is currently still practicing with the University of Utah Sports Medicine Department. Ryan also previously served as the Pac-12 research coordinator for University of Utah Athletics. Ryan is currently part of the medical provider pool for both US Speedskating US Ski team and snowboarding, and has spoken nationally on sports concussions, autonomic nervous system impairment. And Ryan is one of the original authors of the Utah Autonomic Disorders Adaptive Physical Therapy exercise program designed to improve intolerance in individuals with autonomic nervous system impairment. Oh my, that's pretty cool.
Sorry, it's way too long.
But it's okay because I wanted people to understand what we are, who we're dealing with tonight and the background that you have. So, without further ado, Dr. Ryan, please take
Yeah.
the floor.
Yeah, thanks, Matt, for having me. I appreciate the invitation to be on tonight. I hope, yeah, we can provide some insight into kind of how we've incorporated Softwave into our practice at Kutcher Clinic. And to give a little background on the clinic, we primarily see concussion, mild traumatic brain injury, is the bulk of our population that comes through the door. We're also seeing kind of any other general neurologic disorders, neuropathy, things like that, but largely focused on kind of an athletic sports population. So anything from club athletes to high school athletes, and then the professional ranks in college as well. With that, it's kind of a unique space that we're in, different than a lot of places, in that it's a neurology and PT clinic, and so there's a lot of back and forth that goes on between the neurology side and the PT side, and I don't hesitate to say that both sides have been very impressed with Softwave and how it's impacted just our overall plan of care with patients, how we go about things, and I think undoubtedly so, it's improved the quality of care that we provide.
Yes, and we were introduced from my college roommate, John DiAgostino. Shout out to John, who lives out in
Yep.
Park City, who suffered from terrible neuropathy.
Mhm.
And we're going to have you on for our neuropathy edition for next year.
Sounds good.
But John DiAgostino basically said between Softwave and the dry needling that Ryan produced, it literally reversed his neuropathy. So John DiAgostino helped set up the fact that we could get a device out to the Kutcher Clinic in Park City. And I was lucky enough to go train him in early May. And you lined up some of the coolest people in your little community, pickleball
Got
players,
some pickleballers.
yeah,
Yeah, exactly. Yeah.
snowboarders,
Mhm.
mountain bikers, and we got to work on them. And almost before I left, you said, "Hey, Matt, I'd say 80%. How is this with headaches?" And I go, "It's pretty good." I said, "I do the concussion protocol and with some of the pro teams, the NFL teams." And he goes, "Wow, 80% of our new patients are headaches and post-concussion. Is that correct?"
Yep. Yeah. Yeah. It's definitely by far the most significant population we see.
And we should give another shout out to Dr. Jeffrey Kutcher, who is,
Yeah.
can you give a little background on
Yeah, for sure. Absolutely. So Dr. Kutcher, his background obviously in neurology. He's a practicing neurologist, and in his background, he started at University of Michigan, was a team physician there for University of Michigan athletics. And then eventually from that, he was reached out to by US Ski and Snowboard and asked to be their team neurologist. So that's really how it kind of may seem like an odd, oh, we have clinics in Michigan and Utah. It seems doesn't seem like there's a lot of commonality there, but that's how he ended up in Park City, Utah, was he spent a lot of time out there at the National Training Center for US Ski and Snowboard in Park City. And that is where he decided to open up a second practice was out there. And so over time, after US Ski and Snowboard, which he still is the team neurologist for US Ski and Snowboard, getting ready for the Winter Olympics coming up here. Um, he also is the consulting neurologist for the NHL Players Association, the NFL Players Association, Major League Soccer Players Association, and then he is the neurologist for the NBA, meaning that he comes up with all the guidelines and protocols on a league-wide basis. And then trying to think all the other things he's involved in. Team neurologist for the Detroit Lions and the Anaheim Ducks and the Detroit Red Wings. Oh, and then also kind of branching out to that Red Bull. He's the neurologist for Red Bull Athletics and also the WWE. So I think I covered it all. I probably missed a few things, but very integrated into the world of sports on both kind of the protocolizing and guidance as far as guidelines go, but then also from the athlete treatment side, which we both traveled to the athletes depending on where they're at, but also a lot of them come into either the Michigan clinic or the Utah clinic. Oh, Matt, I think you're
Yeah.
on mute. There you go.
This whole series has really been based on how to finish off 2025 really strong and have momentum going into 2026. We talk about riches and niches, and headaches is an area that not a lot of people are able to get great benefits with and results. And roughly half of all US citizens, adults, will experience headaches in a year. About 1 in 6 adults report severe headaches or migraines over a 3-month period. Um, it affects women 3 times more than it does men, and migraines affect up to 39 million people. Um, and severity, 1 in 20 adults will suffer from a headache every day. So this is a part that we have not been able to really do well with, and your clinics across the country are specialized in it. So at the end of our training, I said, "Oh, well, if you got work on headaches," I kind of went through the protocols and what we do. And, basically, I showed some stuff that we did in the occipital area. We lower the hertz to 2.0 because sometimes at the higher frequency, it can create some tinnitus or aggravate someone's ringing in the ear. And then we showed some frontal lobe. Most of your patients have had MRAs, so you know that there's no blood clots. and take it from there. I gave him like a 2 minute little dissertation and
Yeah. Um, yeah, so I think with that kind of if we take a take a step slightly back and look at kind of the physiology of a lot of headaches and specifically looking at kind of migraines and concussion in general, we're talking a lot about the trigeminal nerve. In concussion, that's largely what the bulk of symptoms are produced through is the trigeminal nerve being the largest nerve throughout that runs throughout your brain from a cranial nerve perspective. There's going to be a lot of stress and tension placed on that nerve. Um, the challenge with that nerve is that it connects to a wide range of different physiologic symptoms. Yep, exactly like Matt's showing. So, the trigeminal nerve can have visual implications, can have vestibular implications, cervicogenic implications, autonomic system, vagus nerve, that side of things as well. And trigeminal nerve is essentially the impacting factor as far as hypersensitivity goes in migraine headaches. And so if we take that trigeminal nerve and maybe some research studies down the road, like if we're doing direct stimulation of the trigeminal nerve, but as of now, I don't know how we to do that. So we focus on where the trigeminal nerve kind of intersects with. And so if we're looking at kind of, as Matt said, like you can hit it from a V1, V2, V3 aspect of the face, which a lot of concussion patients have TMJ issues post that, which it isn't that surprising given what the trigeminal nerve impacts. Also, trigeminal nerve, upper cervical spine. So hitting back there, as Matt kind of demonstrated. So that's kind of where we start and like where does the trigeminal nerve go superficial, or what does it innervate or connect to that also is very superficial that we can potentially attack from a soft wave standpoint. So that's really, as Matt said, that's kind of where I started. And like, okay, let's hit these spots, see how people feel. And then it's really just grown from there. One, just doing that, I've had a ton of success. But I would say in my experience, you get like those first one or two treatments, people are like, oh, I feel so much better, but it's not quite there. It's not quite there yet. And I think that's largely due to kind of the nature of the concussion injury or whiplash injury or migraine headaches. A lot of this population spends a lot of time with upper cervical pain. And so they're in kind of this tense posture that over time, that is likely to cause kind of further down the chain some potential issues. So what I've started to do, and this is where I think Softwave has been invaluable, both from a treatment standpoint, but also a diagnostic standpoint. So what I'll do is actually kind of just move down the body, move down the chain from upper cervical, TMJ, even like SCM, and start moving down upper chest, getting anterior posterior shoulder capsule, scapular muscles, even getting kind of in the armpit and getting kind of subscapular muscles, because those are all things that if we think tight upper traps, tight upper cervical, that's going to impact your shoulder position, scapular position. Well, what are all the muscles that are attached to the shoulder and the scapula? Let's move from that joint out and see if potentially there's some more subacute chronic issues that are going on because they've spent so much time in a guarded posture that they're starting to see kind of physiologic changes move down the chain. And that's really for me been a game changer and also eye-opening to patients when you like, oh, let me get in your armpit and try to get subscapularis. And they're like, oh, that is so sore. Like, and you're like, that's our problem. That's our problem right there, is that yes, maybe we've calmed down everything up top, but you still have inflamed subscapularis, which is putting your shoulder blade in an awkward position and your shoulder on an awkward position and not kind of letting it relax, even though we've largely addressed the issue more higher up in that chain. So I think that's largely kind of my strategy when I come to this is, okay, let's start with the obvious. Let's start kind of V1, V2, V3, SCM, upper cervical. Let's see what progress we can make, but knowing that we may very well need to move down the chain and address some of these other muscles that ultimately are being impacted because of that just initial whiplash type injury or kind of migraine, we call it kind of migraine neck tension.
And it's the same way that we work. We start centrally and then we
Mhm.
work distally, even with stroke patients and patients with a chronic type of pain or even, post-surgery injuries. Um, all right, so you started working on this using this, and you I think I checked in with you like every 30 days.
Mhm.
And after about 2 months, I was like, hey, how are you doing with headaches? And you were like, oh my God, take it from there.
Yeah. Yeah, I think so and this has been, and I'm going to expand it just from headaches to even vestibular and visual issues. Um, all those systems are so interconnected. I mean, my background is more on the neurology side, and so I talk to patients a lot about vision, vestibular, proprioceptive systems and how those function. Well, where does a large part of our proprioceptive input come from when we talk about the neck? It's your upper cervical spine. And so oftentimes people come in like, oh, dizziness is my main complaint, or let's say headaches and um or some visual issues. And I'm like, okay, I'm gonna work on your neck first. And they're like, no, 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 my neck's fine. Like I'm getting headaches, or I'm getting visual distortion or blurry vision, or I'm dizzy. I'm like, I know, but let's just work on your neck first. Because if you kind of think about it, if that proprioception or that irritation is still there, it doesn't really matter. I've had so much more success now working on vestibular issues post addressing the neck than I ever did before because we're actually addressing the problem, and that's allowing kind of proprioceptively or from a pain management standpoint those issues to subside. And then a lot of times vision vestibular headaches are improved drastically. But then two, a lot of time my treatment from a vestibular perspective or a vision perspective is so much more successful because we've taken this big chunk of the problem out, and now these systems are allowed to kind of function in the way that they should function or supposed to function, because they're not receiving altered proprioceptive input or having this constant pain stimulus, and so things are reacting differently.
You know, um, with headaches, with
Mhm.
concussions, there is a whiplash component. We have this brain that's in our cavity, right? Protected
Yeah.
by cerebral spinal fluid. You get this trauma. I'm sure you've seen snowboarders, pro football players, college football players. By the way, I was delivering a second device to Miami Dolphins a couple weeks ago, and I
Yeah.
invited the sports medicine team to come to watch this tonight. And they said, "Well, who's doing it?" I go, "Oh, Ryan Pello." And they're like, "Oh my gosh, I worked with him at University of Utah."
Utah. Yeah.
Our boy
Mhm.
Danny from
Yeah. Danny Reyes.
Danny
Yep.
Reyes. So
Uh-huh.
you do have a good reach. Your doctor and your clinic have done some really great things in the professional sporting world. What is it like working on a major athlete who has had a head trauma or has had a concussion, and what is it like bringing them back to um, perform at that level? Can you give us some insight there?
Yeah, for sure. I mean, one, it's a little pressure packed, but I kind of enjoy that aspect of it. I mean, you're dealing with a population that is so dependent on how their body is functioning for their livelihood. Also their success in sports, but which largely then facilitates their livelihood. And I think with that population, there are a few things that may differ them from the general population. And one is kind of the motivating factor. Obviously, everyone wants to improve and get better, um, but no other population is so dependent on being able to function how they used to be able to function than kind of the professional sports population, that again is reliant from an income standpoint on how their body performs. So I think step one is always kind of assuring them that we're going to take the best care possible of them, and we're going to help guide them through this process, and especially with kind of headaches and concussion, there's so much misinformation out there, um, about kind of the impact of concussion on the future of your career, or there's X amount of concussions that someone should have before they are removed from sport or whatnot. And all of that to a large extent is not true. It's not evidence-based at all. It's kind of just been facilitated throughout time through different anecdotal things or whatnot. So first of all, like that education component is a huge part of it, and teaching them that these aren't career ending issues. These are things that, if they're well managed, shouldn't impact your future career, going forward. I think with that population as well, they're not completely always open as far as how they're reporting symptoms and issues. A lot of times there's either from a cultural standpoint or just ulterior motives to get back out there and do things. And we're really reliant on kind of honesty as far as symptoms go, as far as helping us from a diagnostic standpoint and from a treatment standpoint. So I think building that trust that we're out for the betterment of them, and we're here to guide them and help treat them and get them back to where they want to be. And by educating them, you can start to open that door as far as allowing them to open up a little bit and talk about all the symptoms they're having, because there's so many little different bits and pieces that can be helpful from a diagnostic perspective. Um, the other thing we try to do at Kutcher Clinic, and this largely comes from, for the most part, all of the employees of Kutcher Clinic, or all the providers, having worked on both sides of the equation, both like in athletic training rooms or team physicians and things like that, but then also now kind of on the other side where you're more a consulting service and providing kind of guidance, is really trying to work with the teams and their athletic staff. We don't want to ever be thought of as the competition. Like, we just want to be there to actually help. Like, it can be, say, as a team physician or a team athletic trainer or PT, a little bit, you feel like there's a competition if your athlete wants to go outside and get a second opinion or get not. We don't ever want that to be the case. We want to make their lives actually easier, because it's tough enough as it is working with a team and having the pressures of a front office and a coaching staff, um, and constant questions on why this person isn't back, why they're not getting better, what's going on. So we want to be there as a support service and not as any competition, or you're doing it wrong, we're doing it right type of thing. So I think that's another thing that's huge in our world, and kind of the side that we're on is being able to work with people and not try to create some level of competition.
That's awesome. And yeah, so let's kind of go through. So it's important. You said the trigeminal nerves are
Yep.
really one of the first parts that you hit.
Hmm.
If we were going to talk energy levels, I know you've stuck pretty much to the core, the 2-minute protocol I gave you, but
Yeah.
energy levels, what would you say you're ranging? And it's to patient tolerance, correct?
Yeah, to patient tolerance, I'm working at kind of, and again, this is from your guidance. I'm shooting for like a 5 out of 10, 7 out of 10 discomfort level. That can definitely vary a bit based on the patient, but also obviously kind of body part wise. I would say I definitely do probably lower like, if we're talking V1, V2, V3 area. Probably I'd say, if we had to give it an average on intensity wise, um, 7, 8, maybe a 9 or so. Also, always instructing people, and this again came from you, keeping your mouth open. Just kind of can help with that tinnitus type feeling and kind of the echo chamber that you create if you create that closed nasal oral cavity. It's kind of deep, but also educating too. Most people do. They're like, "Oh, my ears are ringing a bit," but educating them that that'll go away. And for everyone, I think it's like, oh, some people longer than others, but everyone's like, oh, an hour. Maybe it lasted a few hours even into the next day, but it eventually went away. But that's where I oftentimes will use a decreased kind of frequency
Yeah.
and getting down to even 1.5 if it's really uncomfortable on a patient or if they're getting a lot of ringing in their ears.
Yeah, that's important to stop and give them a break. Um, and if
Hmm.
we see, so the interval, I might only do for TMJ, I may do 75 pulses at 1.5 hertz. Energy levels should be, like you said, 7, 8, maybe 9 by that second or third visit. You're following
Hmm.
down V1, V2, V3. You're going right along the nerve.
Yeah, I try to get folks a lot kind of down on the jaw. That just because you're still getting that nerve, even though it's just one branch of it, but it seems to be tolerated a little bit more than higher up on the
Mhm.
forehead face. So that tends to be where I focus, but then branching out as tolerated, more V1, V2, and then kind of dropping right down into the SCM and then like upper cervical
And you'll
suboccipital.
you'll come right to the SC joint as well. Follow it all
Yep.
the way down. So
Yep.
you may do 500 pulses per side. What
Mhm.
what would you say is
Yeah, I'd say 500 pulses per side is a good starting point. I would say then second and third treatment, based on how that was tolerated, I may up it a little bit more, or on occasion, there's like, oh, it was really sore afterwards. It did kind of give me a headache. Okay, let's drop it down to 400 and see how you feel. So as all of us as clinicians, like you got to take the feedback you're getting and adjust a little bit. But I think 500, I'd probably start 1.5 and then probably an 8 just to start and see how that's tolerated and then change things up based on that.
and I recommend that if our providers out there want to do this, you should also have a compassion form on file. You could
Yep. We
direct
do have that.
message me to have one of those so you have it on file. Also, of let's say, how many new patients a month do you guys bring in that one clinic, would you say?
In our Park City clinic, it is a bit seasonally dependent and based on where we're located. Ski season, even with football and everything like that, ski season is our busiest season. So we're coming up on that if we could ever get snow out here. Um, but I'd say busy season, we're probably getting even 4 or 5 new concussions a day. So yeah,
A
it's
day.
pretty busy. Yeah, it's pretty busy.
So you could have 8 to 10 new patients a week,
Yeah,
35 to 40 per month.
yeah.
And um, and so overall, I guess just this isn't like we're not putting a research paper yet together, but we might get a
Mhm.
white paper. But
Yeah.
what would you say overall results, first, second, third session? Are people seeing an immediate relief after number one? Are you using it as like you said, as a diagnostic tool to find out if they're good candidates? Kind of walk me through that again, just a little bit.
Yeah. As far as people seeing immediate relief and at least an improvement in symptoms, I mean, that's up there 80, 90%. Like, I rarely, and I've tried to be as skeptical as possible. Like, okay, I'm just, okay, is this really doing what it seems like it's doing? And um, I honestly can't think of many people that have come back and said it did nothing. I don't think I've actually had a patient that said it didn't at least improve symptoms to some extent. Now, um, obviously, as we talked about, concussion can come with a variety of symptoms. But having that first, second, even third visit where you're decreasing neck pain, headache typically decreasing as well. Um, that is such a huge kind of jumping off point to then kind of fine tune whatever else is potentially left from, oh, is it I still have a little bit of dizziness or some visual issues or still getting kind of that migraine component of it. That is the most significant benefit in working with neurologists. They can kind of manage that migraine side as well. And so a lot of times, and I know from a research perspective, this isn't the most ideal because they're kind of confounding, but neurologists kind of addressing things as they typically would from a um, neurologic brain management standpoint, as far as their kind of medication management combined with the PT side and shockwave. And yeah, sometimes I'll throw in dry needling there as well. Um, it's a pretty lethal combination as far as treatment goes. Um, I would say too, I know I mentioned dry needling. I've used dry needling less and less acutely than I did in the past, if that makes any sense.
Now that you have Softwave.
Yeah. Hmm.
You know, we're going to talk a little bit about data biologics. I think every provider that's on this webinar tonight should have sign up. You get 1 year free with the purchase of your Softwave. Data Biologics is a third-party company that is helping track and manage a lot of our cases. So for our clinic in Atlanta, and Jacob Eisold's on it, our operations manager, he helped put this together about 26 months ago. And we're tracking, we can tell that an average patient that comes in with knee pain is at a 7 on a VAS score. And after 30 days, they're at a 2.5 or a 3.5. And then 90 days from the start, they're at a 2.5. And 1 year later, they're at a 1.5. So we continue to see this improvement. And I'd
Hmm.
love you to have access to that for all of your headache patients in the
Yeah,
future.
that'd be
So
fabulous.
I'll have Jacob set you up with that.
Sure.
Secondly, you know, I just December 8th, I was my anniversary for 31 years since I graduated from chiropractic college. And
Nice.
even 4 years like in school. So for 35 years, I've been going around to my professors and at seminars, and I'm always like, where does pain come from? You ever seen that book, Are You My Mommy? You know, where the little duckling kind of walks around and asks for, yeah. I would do that. I was like, where does pain come from? And, you know, uh, I'd have different responses, some that were dissertations, and some were like pain comes from mechanical stress, pain comes from lack of oxygen, pain comes from inflammation, right? I really feel that this tool in the hands of people like yourself and your colleagues, from a diagnostic standpoint, it helps you find out where the true source of injury is. Secondly, it helps you downregulate inflammation. And I remember I sent you a lot of papers at first to get you on board. And
Hmm.
I believe that this technology helps, it gives you like the secret to unlocking that healing component, which is modulation of inflammation. How much is inflammation based on your experience? How much is inflammation part of the concussions and headaches?
Um, I'm gonna say much more than I thought it was post or pre Softwave. And it's become my kind of step one and number one go to, because if there's inflammation, then we're not addressing that, then we're not going to make much progress elsewhere. Um, I think if we're talking concussion and the whiplash that has to occur in order to create the forces necessary to generate a concussion, then um, that neck is going to be inflamed. Um, Neck, upper traps, those muscles are going to be inflamed initially, and if we're not, and this is where the more acutely kind of you can get your hands on someone post concussion, the better. If we can kind of reduce that inflammation as quickly as possible, then a lot of the issues, especially with kind of a prolonged recovery post-concussion, we're reducing kind of all the compensatory mechanisms that your body takes to address or to deal with kind of upper cervical tension, upper trap tension, alteration in posture that comes from having an inflamed neck.
Yeah, I agree with you. I've really over the last 8.5, 9 years of utilizing Softwave, I've seen what a huge component that inflammation, that factor is really the main culprit of a lot of our pain, our patients' pain and suffering. Um, you know, typically on our webinars, we like to share what we call cool success stories for of patients, and maybe we have a segment we call it supernatural healing when we have patients that you just you didn't see it coming, and all of a sudden they're boom. So I know I don't prepare you with any questions beforehand, but
I
I'm
know.
wondering off the top of your head, other than Mr. Diagostino, what would you say anyone that comes to mind that has had some kind of near immediate relief or so happy that they ended up wanting to buy a device?
Um, yeah, I mean, I can I give a couple different things in different realms.
Absolutely. Yeah.
Um, So yeah, I mean, definitely your buddy. That's, I mean, I don't even tell if he talked to you since yesterday, but he hadn't seen. We'll start there. Even if it's neuropathy, so it's not really on topic, but we'll cover it briefly. So Matt's buddy, college buddy, came to me with kind of lower extremity neuropathy that nothing had really touched for years. And so I had been doing kind of a dry needling protocol that I had learned through some continuing education and kind of modified and adapted a little bit myself. And we were having some success. And at the same time, we're kind of overlapping. You had been doing Softwave on John. Um, and yeah, HIPAA out the door. He's okay with it, I'm sure. Um, and then we kind of had this moment, and this is where Matt and I's connection came. Like, well, let's do them in conjunction with each other. And so I started doing dry needling and shockwave like back to back in one session, and like almost immediate results or significantly reduced his neuropathy, allowed him to sleep at night, um, made essentially life tolerable in many ways. Um, so and Matt knows John obviously very well, but so John hadn't come by for like 2 months, and he came by yesterday, and he's like, "I am dying here." I'm like 10 out of 10. He's like, "I can't do anything. Like life is miserable or whatnot." So did the dry needling shockwave. He texted me that night with a few expletives and was like, it's already down to like a 4 out of 10. And like, he's like, I went out for a bike ride. Like, I'm doing great. Like, life is tolerable again.
That's awesome.
Yeah, it's crazy. So the challenge with him is getting him to come in on a consistent basis. That's the problem with your
Yeah,
buddy.
I tell him we might be white and flaky, but we're no aspirin. He can't just come when he hurts.
Hmm.
Um, okay,
Hmm.
that's our boy Johnny Diagostino. Now, over the last
But
7 months, any other good ones?
yeah, I mean, I did have a patient that purchased a device out of pocket by themselves just for home use. Um,
You're in a high
part,
rent zip code up there in Park
yeah,
City. But let's talk
part,
about, we don't have to say his name, but
yeah,
this young man, he was in his early
oh,
40s
early 40s, yeah.
and owns a house out in Park City. Took
Hmm.
his nephew skiing, right?
Yep,
And then coming off the ski lift, he gets the nephew takes his legs out from him and he
yeah,
lands with a helmet on onto the ice floor,
yep,
cracks his helmet open. This guy is. he's a very important person, and it has done very well in business. And he
Mhm.
needs his brain. And he was having post-concussion issues, memory issues, brain fog. He was not himself. He was irritable, and talk about he'd been to doctor after doctor. Then he came to see you like a month
Yeah.
or 2 months.
Yeah, he
He
was
got
he
everything
was
from
a
there.
he was a fair bit post injury and just yeah, nothing had really helped and I think it kind of speaks to the world of concussion that um there is no one size fits all approach. Um I think Softwave is the closest thing as I've experienced to that, but it's still there's no one size fits all approach. And so a lot of the treatments that he had been tried were kind of generic things or just going through the motions and never really stepping back, looking at the big picture and seeing what's going on. And he's one that perfectly illustrates kind of that point where if you address some of the things that are going on from a kind of V1, V2, V3, TMJ, SCM, upper cervical, and you all of a sudden see all these other symptoms that you wouldn't necessarily relate. Like you just said, like the brain fog, the cognitive function, the memory, dizziness, things like that, those all start to improve. Then it's like your aha moment when you're treating concussion. You're like, this is all being generated, or primarily, I like to talk to concussion about like what's the generating factor and then what are all the systems that are a consequence of that generating factor being impacted. And we addressed his neck and SCMs and he's like, oh, like the fog has lifted. Like, and that was after like one session because he's in and out and whatnot. And he's like, I'm sold, I'm buying one for my other house. Um,
In
and so
Florida. Yeah, yeah.
yeah. And so it's and that's where treatment standpoint, obviously it speaks for itself, but that's where from a diagnostic standpoint, there's so much value is that it clearly then demonstrates, okay, a lot of the issues you're having are being generated by your neck. And if we address that, now maybe there's some fine tuning after that, but we've got to take care of that number one, um, in order for you to make progress or get back to being you.
Dr. Ryan, we have a question from Dr. Ralph, and he says, Dr. Ryan, any insight when it comes to post-traumatic spinal cord injuries that you found, or have you been working with anyone? Nice question.
Yeah, great question. I have not, we don't see spinal cord injury much in our clinic, um, or really at all in our clinic, but God, that's an interesting area to look into as far as soft wave treatment goes.
And
I
we can,
think,
yeah, I can
yeah,
bring up, I mean, in 2019, the Austrian healthcare system created spinal injury pilot study, and they have created a national health mandate that any spinal cord injury patients get soft wave treatment within 72 hours.
that's fascinating. Yeah.
Yes. And so in the 5, 6 years it's been running, they've had a 50% reduction in spinal cord paralysis. And if you look at a small country that has 7 or 8 million people, um, if you can have help a couple people from not being full paraplegic or
Mhm.
quadriplegic, it's huge. Um, I'm going to probably have Dr. Tim Del Medico on because he's been working with a wonderful we have a great story of one of his associates who had a spinal cord injury a year ago, and Dr. Josh Pryor, who keep him in your prayers. A year later, he's dealing with this injury, but Dr. Tim Del Medico has been treating him for months, and now he has movement in his left toe, big toe, after a T9, T10 complete fracture. So very promising. We also just got Dr. Josh his own device about a month ago, so he's able to treat every other day, every 3 days, and it's really promising. So one of our best stories ever happened right out in Park City, where Daniel Pompa had a spinal cord injury, and It's Dan Pompa's son, and we literally had a device there 3 days after he got out of the trauma center. He had fractures in two different areas of his spine. They recommended surgery and hardware. He opted not. They said he had to lay horizontally for 12 to 15 weeks. He literally was 5 weeks after went backpacking in Greece. So amazing story of healing, and that's one of our podcasts from 2019, I believe. All
All
right.
right.
Well, listen, I know I'm very grateful that you were able to take time
Yeah,
in the middle of the
absolutely.
holidays. See if we have any other questions. It was very enlightening. I guess we should end with what contraindications maybe we would stay away from. Um, let's talk
Yeah,
about.
no, I think that's a good question. And for large part, all our patients for the large majority are getting MRI imaging from a brain standpoint. So we know if there's any active bleeds or what's going on there. I think I would probably stay away from that, given the mechanisms by how Softwave functions. Um, but yeah, I think you always want to screen for since this is going to have an impact on vascular flow and whatnot. I think you always want to proceed with caution or even stay away from kind of some of those more vascular compromising type pre-existing issues or whatnot.
Right. We'd never run it over a tumor or
Yep.
a malignancy. If someone's had some dental work or cement, you gotta, that should be a factor.
Mhm.
In 8.5, 9 years, I've had one provider tell me that they were working on TMJ and loosened up some dental work. So these are smaller issues, but things that you have to think about. And again, we talk about it. If they have a history of tinnitus or ringing in the ears, this could aggravate that.
Yeah. Yeah,
Um,
and I would say I definitely because that is a common complaint post-concussion. For me, it's not a direct no, but it's just something to educate the patient on that like this can have an impact on that and may worsen things. It's typically temporary, but you want to educate beforehand.
um, yeah, and finally, I mean, if you guys haven't seen the video at Dr. Dennis Brown's office in Atlantic Highlands in New Jersey on the young lady who had trigeminal neuralgia, and she couldn't eat, she couldn't talk, she couldn't speak. And it was in 1 month before her wedding, and we did a handful of sessions, and I know she, within 24 to 36 hours, she had, had 60% improvement and went on to be able to eat, talk, and drink again, which are essential in your everyday to stay alive. Um,
Yeah.
Ryan, on that note, I think we're going to let you go, get back to your family, and enjoy these beautiful holidays, and hope to see you again in the spring when we go over some of our neuropathy protocols. Okay?
Love it. Appreciate it. Thanks
All right.
again. I'm honored to be a guest.
Thank you, sir, and have a good night, everyone. Appreciate it.